What's up, Ninja Nerds? In this video today, we're going to be talking about chronic lymphocytic leukemia, also known as CLL. If you guys like this video, if it makes sense, if it helps you guys, please support us. One of the best ways that you guys can go about doing that, and it really does go a long way, is by hitting that like button, commenting on the comment section, and please subscribe. Please. Also, if you guys get a chance, down in the description box below, we have a link to our website where we have some amazing notes, some amazing illustrations that I truly believe that if you guys follow along with me and fill that out as we go along, I really think it'll aid in your understanding of this topic. But let's get into it. Let's talk about CLL. So CLL, just like we talked about this, and again, at this point, you should have watched all the acute leukemias, my friends. You should have gone over AML, ALL, and if you have, I would suggest you watch CML, and then this will be the last one, CLL. And then we'll move on to lymphomas. But at this point, what you should understand, and the difference really is critical, is between the acute and chronic leukemias. Acute leukemias, usually when you look at them, there's an alteration in both of these leukemias, chronic and acute, in the hematopoiesis pathway. But one of the big differences is that acute leukemias, they affect really close up, like towards the actual stem cell component. So they were affecting more of like your lymphoblast, they were affecting more of your myeloblast, and they were replicating, but never differentiating. And that's why they develop super rapidly and develop symptoms and problems very acutely, right? Where they wouldn't really make many functional lymphocytes or many functional granulocytes. Whereas in CML and CLL, what happens is, it starts where the myeloid stem cell and the lymphoid stem cell, they proliferate, but they do differentiate and become white blood cells. They become functional or mature like granulocytes, are functional and mature like lymphocytes. And so that's really the big difference here. So when we talk about this one, again, we start off with the hematopoiesis pathway. This is what occurs in the actual red bone marrow. Starts off with what's called a hemocytoblast. Then it becomes a myeloid stem cell, which we talk about more specifically in the AML and CML lectures. Now what we're going to do is we're going to focus more on this side, the lymphoid stem cell, which will then kind of become a lymphoblast. And then it'll become what's called a pro-lymphocyte. And then eventually it'll become a lymphocyte. And there's two different types. There's a T lymphocyte, and there is a B lymphocyte. And what's really happening in this particular process is that your lymphoid stem cells are really just kind of undergoing this excessive clonal proliferation and monoclonal kind of expansion. And so what's happening is these lymphoid stem cells are kind of just replicating like bunnies, making lots of lymphoblasts. Lots of lymphoblasts are actually replicating and differentiating, becoming prolymphocytes. And then lots of these prolymphocytes are actually differentiating and becoming B lymphocytes. Now you're probably like, oh wait, I know that in ALL there was a T cell ALL and a B cell ALL, because there was lots of T lymphoblasts or B lymphoblasts, right? In CLL, it primarily only affects the B lymphocytes. And so what happens is there is just these massive amounts of mature or small appearing lymphocytes, particularly B lymphocytes, within the bone marrow and within the bloodstream. And that's really what it comes down to. And so this is really where the process is occurring, is that you're having lots of proliferation, but at each stage you're differentiating, and you're making lots of fully differentiated mature small lymphocytes. Whereas in ALL, you were replicating at this lymphoblast stage, but never differentiating them into complete mature functional lymphocytes. That's the big difference here, my friends. So the question then comes, why is there so many lymphocytes? What's the reason why these cells are rapidly dividing and differentiating? I don't have the answer. I don't think anybody really does. And that's the problem with this one, is that there's really no true underlying reason, genetic problem. It could be due to ionizing radiation. It could be due to certain environmental hazards, but there's nothing that's really been shown and studied and actually something that you can rely on to be the cause. And that's really interesting. So the question then kind of comes is, okay, I know that I have the lymphoid stem cell making lots of lymphoblasts making lots of prolymphocytes, and lots of prolymphocytes funneling in and making tons of these B lymphocytes. But the reason why this happens, not a clue. What I do want you guys to take away from this one is that this is most common in patients who are usually greater than 70 years of age. And that's really it, is that this is most common in ages greater than 70 years old. So you can be thankful that there's not a lot to actually have to know as to why this actually happens. And I'm sorry, there's no true answer, but the basic pathophysiology of it is that we know that there is tons of mature lymphocytes being produced due to excessive proliferation and differentiation. Reason why, we don't know. All we know is that this happens in older individuals. Could be idiopathic, could be environmental exposures, we don't know. But now let's talk about the next stages, which is I've made tons and tons of lymphocytes. What's the downstream effects of that in the bone marrow and in the blood and in the tissues? All right, my friends, so now we get to talk about the next component here, which is, again, we have a patient who has CLL. And with this problem, they have this excessive expansion, monoclonal proliferation of massive amounts of lymphocytes. When they have all of these lymphocytes that are kind of in their bone marrow, what are some of the negative downstream consequences that are going to occur? Well, one of the big things here is that you are having lots and lots of lymphocytes that are being produced here. And what starts happening is that over time, some of these B lymphocytes, some of them are mature, but they may be not as competent as I would actually like to say. So yes, in this particular process, what may actually happen is you make lots of mature, so you actually increase the number of mature, but let's call them slightly less competent. So we'll call them incompetent B cells or lymphocytes. So because of that, because you get a lot of these like lymphocytes that are mature appearing, but they're not as competent as they should be, one of the downstream negative consequences of that is that you make plasma cells from these lymphocytes. Some of these lymphocytes are supposed to convert into plasma cells. And so then you get decreased competent plasma cells. And then if your plasma cells are not completely competent, then they aren't able to produce things like what? Antibodies. So now, if they aren't able to produce antibodies, that means that you will have less antibodies being produced. And this is called hypogammaglobulinemia. And antibodies are supposed to be able to bind on to pathogens, viruses, bacteria, tag them to be eaten by right white blood cells, activate the complement system, just really enhance the inflammatory reaction and clear pathogens from the bloodstream. But now, if I can't actually do that and I have less of these actual gamma globulins present, now the downstream negative consequences of that is that I have a high risk of infections because I can't tag these pathogens and enhance the destruction of these pathogens. And so now the downstream consequences of a high risk of infections. And these infections can look various different ways. So what are the ways that they can present? They can present with pneumonia. They can present with urinary tract infections. They can present with cellulitis. So these are the downstream things that can actually have a high degree of mortality in some of this patient population. So that's one interesting type of effect. You will make a lot of these lymphocytes and they will look mature, but they may not be as competent and as functional as normal produced lymphocytes. And that's the important thing to remember. The other thing is that you have to remember, it's just like in acute leukemias. When you have all of these actual lymphocytes that are being produced, they start kind of crowding out the bone marrow a little bit. Not as much as in compared to like, whenever you have a patient who has CML, they don't really crowd out the bone marrow until they start getting into the accelerated, into the blast phase. But this one's kind of similar. They produce so many different types of lymphocytes that these are enough to kind of crowd out the bone marrow a little bit. And because they crowd out the bone marrow, they can drop all the other cell lines. So you can actually drop your neutrophils, you can drop your red blood cells, and you can drop your platelets. And the reason why is there's less space and less nutrients available for these cells to be able to be produced. And so you drop other cell lines, which is just like you would see in AML and ALL. So what could I see out of this? I could see neutropenia. Less white blood cells, particularly the ones that really help with fighting off infections. And so now if there's less neutrophils, there is a high risk of infections, promoting pneumonia, UTI, cellulitis, other opportunistic infections. The other thing is that there's less red blood cells. So now you end up with anemia. And this can present with pallor, this can present with dyspnea, and this can present with fatigue. And then the last one is you could have thrombocytopenia. And with thrombocytopenia, this could actually cause bruising, which can look like petechiae. It can look like ecchymosis, it can look like purpura, or it can actually cause full-on bleeding to be present. Gingival bleeding, epistaxis, GI bleeding, etc. So look for anemia, neutropenia, and thrombocytopenia. And so this is interesting because you're like, well, this wasn't the same in CML. And you're right, it's not. In CLL, though, there is enough crowding of the actual bone marrow to cause these particular types of problems. All right, my friends, so now we have to talk about the next component here, which is when we have a lot of these lymphocytes that are actually in the bone marrow, they're replicating and they're going crazy, and then they start pushing themselves into the bloodstream. What are the downstream kind of consequences from that? So similar to ALL, we already talked about this, they do have other cell lines being affected, right? So they can potentially see some neutropenia, they can see some anemia, they can see some thrombocytopenia. Now, the other thing that's really interesting with this one, and they don't really have a lot of bone pain, so that's a big thing that actually helps to differentiate CLL from ALL as well. But nonetheless, one of the big things is that when you get a lot of these actual leukocytes, particularly lymphocytes, so they're gonna have like a crazy lymphocytosis. So they will have an insane lymphocytosis. We see like greater than like 5,000 cells per like millimeter cubed of blood is really the way that you look at it. But that's a pretty, alarmingly high amount. When that happens, one of the big things is that maybe some of these cytokines that are released from these lymphocytes, like you may see things like interleukin-1, tumor necrotic factor alpha, they may help to be able to trigger your hypothalamus to kind of turn on that thermostat a little bit higher. And so it may kind of trigger like these low-grade like fevers, and it may trigger like these night sweats potentially as well. So these are some kind of constitutional symptoms that you may potentially see associated with that high lymphocytosis. We talked about this in CML. So in CML, they had that crazy leukocytosis, sometimes in the 200,000s. And so some of those cytokines can be released as well. And that may trigger this process. And the next thing is that you can actually have some of these lymphocytes get deposited into the lymph nodes. And when they do that, you can form something called lymphadenopathy. And this is an interesting kind of term. So remember we said in ALL they get lymphadenopathy, lots of lymphoblasts deposit into the actual lymph nodes. The same thing, you can get a lot of these lymph nodes that deposit into the lymph, a lot of these lymphocytes that deposit into the lymph nodes and cause them to get a little bit bigger, lymphadenopathy. But with that terminology comes a little slight additional terminology. So we say that CLL is really a massive amount of these lymphocytes within the bloodstream and in the bone marrow. But when it actually causes a lymphocytosis and a lymphadenopathy, so CLL plus a lymphadenopathy, that's actually called something else. We call it small lymphocytic lymphoma. So we actually technically give this next name called small lymphocytic lymphoma, which is where these leukemic cells kind of deposit into the lymph nodes and cause lymphadenopathy. That is called small lymphocytic lymphoma. Now, sometimes this small lymphocytic lymphoma can kind of cause a really, really scary, hard kind of like core of lymphocytes to kind of really become a scary, high-grade tumor. When that happens, it can cause something called a Richter transformation. And with a Richter transformation, what you get is you get that small lymphocytic lymphoma, which is basically CLL lymphadenopathy. But what happens is it transforms into a high-grade lymphoma. And so what happens is you actually get, well, we're going to kind of use these synonymously, CLL or SLL starts to convert into what's called diffuse large B-cell lymphoma. This is a high-grade neoplasia, a high-grade lymphoma. Very, very nasty type of disease. And this is another big high-yield thing that differentiates CLL from ALL. Okay, so lymphadenopathy, Richter transformation. We also can see some constitutional symptoms, fevers and night sweats, potentially from a predominant lymphocytosis. The other thing is that these kind of lymphocytes can deposit into the liver, they can deposit into the spleen, and when they do that, they can cause something called hepatosplenomegaly, which you also saw in, what other disease? You also saw this one in ALL. You only see splenomegaly in CML, and you don't really see any hepatosplenomegaly at all in AML. Okay, With the hepatosplenomegaly, what could be some potential features that they present with? They may present because it's taking up a lot of space. Your liver's getting bigger, pushing on the stomach and the small intestine. Spleen's getting bigger, pushing on the stomach and some of the small intestines. Because of that, it's going to cause decreased kind of like digestion, decreased ability of kind of eating. And so you may have nausea, vomiting, you may have poor appetite or anorexia. You may feel full very, very quickly. So there may be a sense of what's called abdominal fullness. So these are potential things to watch out for. The last one here is that you'll notice that as you get a lot of these mature, so a lot of mature, but very little competent lymphocytes, so B cells, some of these gain the capacity to produce unnecessary antibodies that like to attack our own tissues. Son of a gun, right? And these are called autoantibodies. Autoantibodies. And what happens with these dang autoantibodies is that they like to go and attack other tissues of the body. And so what they'll do is they'll attack our red blood cells and they'll attack our platelets. So now here we're going to draw like a red blood cell here. And when you attack the red blood cell, it's actually nasty effect. And then you can also attack over here, we'll draw the platelets. So this comes up with now a different name. What's interesting though, is that when these autoantibodies attack the red blood cells and they attack the platelets, it causes these to start kind of like lysing, ripping, and kind of getting destroyed. And what happens is this leads to a drop in the amount of red blood cells because you're cutting and lysing them open. We call this autoimmune hemolytic anemia. And then when you bust open these platelets and destroy them, this is called ITP, immune thrombocytopenic purpura. Now, what's important to remember is that you may see this in patients who have CLL. But another kind of golden nugget that you don't want to miss, and they may ask you on the exam, is that a combination of autoimmune hemolytic anemia and ITP in the presence of CLL is often referred to as Evans syndrome. And I don't want you guys to forget that. So don't forget that one as well. The last potential thing that you could see, I'd say it's relatively uncommon, but if you get a large number of lymphocytes, you have to really have a ton of lymphocytes, lots of antibodies and proteins and things like that that are abnormal. These can really kind of clog up. Lots of proteins and lots of cells make the blood very viscous. So when you have increasing cells and you have increasing proteins, this increases the viscosity of the blood. And whenever you increase the viscosity of the blood, it can produce this rare situation called hyperviscosity syndrome. And the primary way that these patients present is with a headache. But that's really hard because a lot of patients can present with headaches, and this is a rare occurrence. So what you'd have to have is a certain degree of clinical gestalt to really find this. You would have to have a severe headache and crazy high lymphocyte levels to really have a suggestion of hyperviscosity syndrome. So now at this point, let's now move on to the next step, which is how do we diagnose this? All right, my friends, so now we can talk about the diagnostics of CLL. So we have a patient who's coming in, 70 years of age or older, coming in with kind of features of maybe some lymphadenopathy, maybe some fever, some night sweats. Maybe they also have potential features of some other problems like hepatosplenomegaly. And then also you get some blood work done, you find some anemia. Could be due to two things. Could be due to decreased space from lots of lymphocytes or autoimmune hemolytic anemia. You can see some thrombocytopenia due to autoimmune effects, or it could be due to decreased space. You may see some effects of some crazy lymphocytes on their actual CBC, with again more of a predominance that lymphocytes are super high with all the other leukocytes. You may see a drop in the neutrophils as well, and then higher risk of infections because of the hypogammaglobulinemia and less neutrophils being produced. And then again, you may also potentially see the hyperviscosity syndrome, not as common. But if you think about this, a CBC with peripheral blood smear would be a gateway kind of test to really help us to have a high degree of suspicion. So with this, what I want to do is I want to look to see, okay, will I have any effect on my red blood cells, my platelets, my kind of other granulocytes or white blood cells, and then the lymphocytes? All of these things are going to be affected. I can see low red blood cells, low platelets. I may see some problems with my neutrophils. So there may be a plus or minus low neutrophils. And then on top of that, for the lymphocytes, I'm going to see a massive amount of these lymphocytes. So what are some of the downstream effects? I can see low red blood cells. What is this called? Anemia. This could be due to decreased space from lots of lymphocytes proliferating, or it could be due to autoimmune hemolytic anemia. How do I differentiate this one? This one you'll have to have features of hemolysis. LDH will have to be elevated, haptoglobin will have to be low, and the direct antibody or Coombs test will have to be positive. That's one way. I also will have low platelets. This could be due to decreased space, but it could also be due to ITP, which was due to the autoantibodies. And what's the combination of ITP and IHA? Autoimmune hemolytic anemia, it's called Evans syndrome. I also may see potentially low neutrophils. This may progress with increasing risk of infections. And there may be increasing number of lymphocytes. And with these lymphocytes, they're mature appearing, but they're less functional. And because of that, there may be less antibodies being produced. So because there's less antibodies and less functional neutrophils, or less neutrophils in general, you have a high risk of infections, pneumonia, UTI, skin infections, etc. The other thing that's really interesting is that when we look at this, we can do something called a peripheral blood smear. And what happens is when we take these lymphocytes and we put them onto a peripheral blood smear, they do not like being on a peripheral blood smear. They actually get smushed and they pop open. And then what happens is they form these weird cells called smudge cells. I'm not even kidding, this is what we call them, smudge cells. If you see smudge cells, I want you to think about this: crushed little lymphocytes. It's literally, you take the lymphocytes, they're so fragile, when you put them on the slide and try to get the smear going, they literally just kind of like pop and rupture open. And they look like these things called smudge cells. If you were to get some lymphocytes though, you should see a lot of mature appearing lymphocytes, small mature appearing lymphocytes. And that's really what you would get off of your CBC with a peripheral blood smear. So look for evidence of high amounts of mature appearing lymphocytes, low neutrophils, low platelets, low red blood cells. The next thing is, what about a bone marrow biopsy? Would this actually be helpful? Believe it or not, not really. It's actually not super useful, and it's not super diagnostically definitive either. The reason why is it's great for ALL. It's not great for CLL. Because the reason why is, if we take a chunk of the bone marrow, you know what we're going to see? We're going to see an increasing number of small, mature appearing lymphocytes. And that may be helpful because when you see this, you think CLL. If you saw a ton of large, immature appearing blast cells, almost greater than 20% lymphoblasts, then you would start thinking about ALL. So this is way more helpful for ALL and not as helpful and useful and diagnostically definitive as in CLL. Now, if we've done the CBC with peripheral blood smear and CA, crazy lymphocytosis, how high? I wrote it over there. Let's actually write it again. This has to be, sometimes lymphocytes have to be greater than 5,000 cells per millimeter cubed of blood. So if I see a high lymphocytes, I see low platelets, I see low red blood cells, plus or minus maybe a low neutrophils or neutropenia. I don't need the bone marrow biopsy to really help me. And then I get the peripheral blood smear and I see smudge cells or increasing small mature lymphocytes. I think CLL, especially if you got a crazy lymphocyte count and then some of the other features. What I would consider is an immunophenotyping. I don't even think that this is crucial as well, but it may help. Immunohistochemistry, not super applicable here, but what is maybe applicable is this flow cytometry. And so when we talk about there's ALL and then there's also CLL. And pretty much the most common cell of the lymphocytes to be affected is the B cells. 80% of them is present in B cell ALL. And pretty much CLL, it's only the B lymphocytes that are being affected. So when we do this, we look at flow cytometry. We're trying to take those antibodies, tagging specific cluster differentiation proteins that are present on the actual lymphocytes. And when you tag them, it'll give you specific proteins that are very indicative of a particular type of cell. In this situation, if it's a B cell ALL, you're looking for very specific ones. And oftentimes this is things like CD10, CD19, maybe even CD20. But for B cell, for the CLL, the most important differentiator is CD5. And you can also see some similarities, CD19, CD20, there's even another one called CD23. So you see some degree of similarities here, right? But what's the big one that kind of like telltale here? CD5 for CLL and CD10 for B cell ALL. That's a really important thing because it may be somewhat helpful in differentiating these two if it really is confusing, but it shouldn't necessarily be, because oftentimes you can get a lot of information just from your CBC peripheral blood smear. The other thing is that there is no need for genetic studies. You want to know why? Because if I do a cytogenetic study, there is no specific chromosomal abnormality or genetic disease that's been associated. Remember when we went through the causes? I didn't write anything down for any genetic disease, any chromosomal translocation or anything like that, because there hasn't been any identified for CLL. So it's not actually helpful to do any cytogenetics or PCR testing. Immunohistochemistry, there's nothing really specific there as well. What I would say is CBC with peripheral blood smear and a differential is helpful. And then you can consider the bone marrow biopsy, and then a flow cytometry may also be useful. Oftentimes, these additional tests will just be helpful in kind of assisting in the diagnosis. Just like we said in ALL, they also have hepatosplenomegaly. So ALL has hepatosplenomegaly, CLL has hepatosplenomegaly, and CML only has splenomegaly. There's no hepatosplenomegaly at all in AML. But if we wanted to find hepatosplenomegaly, we could do an ultrasound of the spleen or the liver, or the the right upper quadrant, or we could do a CT of the abdomen to find that. And then, if I wanted to see a lot of these leukemic cells, a lot of these these lymphocytes that were present in the lymph nodes, I could do a lymph node biopsy. And I could actually take a look at these cells and look to see if they look like small, kind of mature appearing lymphocytes versus lymphoblasts. So that's some of the big things. And also, what's another thing for lymph node biopsy? If I take this, it could also help me to find out, is there any diffuse large B-cell lymphoma, which was due to what process? The CLL converting into diffuse large B-cell lymphoma is called Richter transformation. So that's another important thing to be able to identify. So at this point, we should have diagnosed CLL. Now the question is, how do we treat it? All right, my friends, so now we get to talk about the treatment of CLL. So in this situation, one of the ways that we determine the treatment is we look at what's called their classification system. And really, it's the RAI classification system. It's the way we actually help to determine the degree of severity of a patient's CLL, which will determine their degree of treatment. And that's a really, really important thing. So this is pretty high yield. I do want you guys to remember this. So we have RAI 0, 1, 2, 3, and 4. And obviously, as we go this way, the more severe the CLL is, the more likely we're going to be a little bit more aggressive with the treatment on these ends. So let's go through this. The first thing is you have RAI 0. What is this indicative of? So really the key thing for CLL that we've kind of picked up is a persistent lymphocytosis. Greater than 5,000 per millimeter cubed of blood has been kind of the big overarching theme. So that's the first thing. So what I want to see is I want to see the presence of lymphocytosis. If that's present, that's at least going to be RAI 0. But let's say they have nothing else. The next thing I said that was really, really important is they have a lymphocytosis. So now we're going to go into the next kind of classification system. The next thing is that I told you lymph nodes are always affected in CLL or ALL. So I will see lymphadenopathy involvement. Then I go to RAI 2. So now I have a persistent lymphocytosis and I have a lymphadenopathy. So what was that called whenever you have CLL plus a lot of lymphadenopathy? It was called small lymphocytic lymphoma. But then the next thing here is the other organs, hepatosplenomegaly. So then if they have some hepatosplenomegaly, that's the next organ to be commonly affected in CLL. So the same thing, RAI 3, they'll have lymphocytosis. They will have lymphadenopathy. They will have hepatosplenomegaly. And then the next thing is that they could have anemia. This is usually not the anemia associated with autoimmune hemolytic anemia. So I need to make sure that you remember this is not autoimmune hemolytic anemia. This is the anemia due to decreasing space from rapidly developing lymphocytes. Really important, my friends. Then the last effect here is you have a lymphocytosis. Right, so you have to have a lymphocytosis to have CLL. You have to have a lymphadenopathy. Then if you have the hepatosplenomegaly, we have a lot of organ involvement. And then we said after hepatosplenomegaly, you have to have anemia to be RAI 3. The last one, which is again not autoimmune hemolytic anemia, the last one is thrombocytopenia. And it cannot be ITP. So you're probably like, okay, Zach, how in the stink am I supposed to remember all this? The next thing is if the patient is RAI 0, 1, and 2, and they're asymptomatic. So we'll kind of put this as like this. We'll put asymptomatic RAI 0, 1, 2. You do nothing. You do nothing. You observe these patients. So what I want you to remember is this is observation. It's better to avoid any kind of treatment process for these patients. If the patient has symptomatic RAI 1 and 2, 1 or 2, then you should consider treating these patients. Then you will consider treatment of these patients. Then you can do treatment. And this is usually chemotherapy, which we'll talk about in a second. The last component here is if the patient is RAI 3 through 4, regardless if they're symptomatic or not symptomatic. So RAI, doesn't even matter if they're symptomatic or asymptomatic. 3 or 4, these patients will also get treatment with chemotherapy. So this is an important thing to be able to remember. So it seems as though as if you kind of get RAI 3, 4, you go to treatment, chemotherapy. If it's RAI 1 and 2 and you have some degree of symptoms, like what kind of symptoms? Well, if you have any kind of severe problems such as maybe at this point you start kind of getting like features of hepatosplenomegaly, right? Or problems associated with lymphadenopathy, or the lymphocytosis is causing other kind of downstream effects. These are big things to be able to remember. Now, the question then comes, okay, we're going to treat these patients with chemotherapeutic agents. What are we going to treat them with? The agents that we generally give for these patients it depends. So if they are younger, they'll get a specific treatment. And if they're older, they'll get a specific treatment regimen. So for the younger ones, we do kind of like a 3-part regimen. And 3-part regimen here is actually, it's 3 particular drugs. So these 3 drugs I want you to remember is fludarabine, so fludarabine. The other one is called cyclophosphamide, so cyclophosphamide. And the last one is called rituximab. These are the 3 treatments. If you guys do forget them, the way I remember them is FCR. So fludarabine, cyclophosphamide, and rituximab for the younger patients. For the older patients, these tend to respond better to a specific drug called ibrutinib. Okay? So you might be, okay, Zach, how am I supposed to remember all of these chemotherapeutic agents for AML, ALL, CML, CLL? Really, when it comes down to it, for the chemotherapeutic regimen in AML, it wasn't like a ton. It was really the primary things that you saw within that was cytarabine, and the other one was idarubicin or daunorubicin. For the ALL, that was the CVAD, right? And so for the CVAD, it was the cyclophosphamide, vincristine, asparaginase. There was also the dexamethasone and the daunorubicin. The other thing for AML, what I think was more important is to remember the ATRA, the all-trans-retinoic acid, and arsenic trioxide was the really big thing to remember. That was for the APL subtype. For CML, it's always tyrosine kinase inhibitors. And then for this last one for CML, remember FCR, fludarabine, cyclophosphamide, rituximab for the younger patient population, and then ibrutinib for the older patient population. If they fail the chemotherapy, so they fail chemo, then what we do is we move them to the next step, which is a bone marrow transplant. And that's usually an option for every single type of leukemia if they fail the normal chemotherapeutic regimen or immunotherapy, whatever it may be. My friends, in this video we talked about CLL. I hope it made sense. I hope that you guys did really enjoy it. And as always, thank you, love you, and until next time.